I'm Dr. Laura Lacher, and we'll begin with just a few announcements and reminders before we get started for the day. Please be sure to join us next week. We will be hearing from Dr. Alec Saltman, who will be giving a discussion of best practices in urine drug testing. And I am here at Providence St. Vincent Medical Center, here live in Southern Auditorium. And welcome to all of you who are joining us virtually on Teams Live. This is a collaboration between us here at St. Vincent and Providence Portland Medical Center. Please stay tuned every week to see if you can join us here in person or whether the talk is available only virtually. That information is always in the invite each week. You can earn CME credit for being with us here in the room, for watching live virtual, or by watching a recording of the session. And that recording also is available at the same link as the Grand Rounds invite. I will be monitoring the Q&A throughout the session today, so please go ahead and post any comments or any questions that you have, and we'll mostly hold those until the end as time allows. And now I am very delighted to introduce today's speaker, Dr. Kate Marshall. She is a member of the Department of Addiction Medicine at Kaiser Permanente Northwest. Kate is a familiar face to many of us, and so happy to have her back. She earned her medical degree from OHSU and then completed internal medicine residency and served as chief resident here at our own Providence St. Vincent. She then went on to do fellowships in addiction medicine and internal medicine at OHSU. Dr. Marshall has very quickly emerged as an education and clinical leader, currently vice president of the Oregon chapter of the American Society of Addiction Medicine, and will serve as president of the chapter for the 2023-24 calendar year. Dr. Marshall, thanks for coming back to teach us, and as always, bringing us your excellence and your enthusiasm.
Thank you so much. Great to see you guys. All right, let's get started. So my hope is that, first of all, just so excited to be back at Providence. Want to thank all of my colleagues and mentors for their support and encouragement in finding my way to the medical specialty of addiction medicine. In case you're wondering, I'm enjoying it immensely, even if I do miss all of you now that I'm over at Kaiser. But let's get started because there's a lot to cover today. By the end of the presentation, I hope that you'll be able to describe the changing landscape of non-prescribed opioid use in the US and the forces behind that shift, contrast some complications and challenges of fentanyl use compared to heroin use, talk about some recent and upcoming changes to regulation around prescribing of buprenorphine and methadone. We're going to talk about several novel strategies for initiation of buprenorphine in the setting of fentanyl dependence. And we'll describe some additional supports for patients working to stop their use of fentanyl. So before I go on, I have no conflicts of interest, no financial relationships to disclose. I do discuss off-label initiation strategies and use of a couple of medications, as well as off-label maintenance doses of buprenorphine, and we'll label those as such. Also, before we get started, I'd like to start with a reminder of the American Society of Addiction Medicine's definition of addiction, right? Addiction is a treatable, chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. And that often includes chronic stress, trauma, and then, of course, heritable qualities. And people with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. I also want to mention that evidence shows that the use of stigmatizing language like addict or abuser, or even saying that somebody's urine test came back dirty for a substance, it actually harms patients' ability and likelihood to engage with care. I'll try to stick to person first, medically accurate, morally neutral terms as recommended by the National Institute on Drug Abuse and other federal agencies. I hope you'll continue to pay attention to the language that you use as well. So to guide us today, I am going to examine this issue through the experience of 3 patients I've worked with in the last few months. Names and some clinical details have been changed to protect their identities. So first we have Sonia. She is a 39-year-old woman with a history of anxiety, depression, and polycystic ovarian syndrome who presented to a new OBGYN to establish care. She reported that over the last 6 months, her menses had become more irregular. Her menstrual cramps were now constant and almost unbearable. And workup unfortunately revealed endometrial adenocarcinoma. And she was referred to gynecologic oncology to plan a hysterectomy. During surgical planning, she informed the surgeon that she had started swallowing oxycodone 30-milligram pills that were given to her by her brother to relieve that unbearable abdominal pain. And she recently learned that they contain fentanyl. She's tried really hard to stop taking them, but developed severe withdrawal symptoms and hasn't been able to stop. She asked for help. Next is Ray. He's a 65-year-old man with a past medical history of opioid use disorder in sustained remission on buprenorphine therapy, who presented to his Suboxone prescriber, me, reporting that he had a return to use of non-prescribed opioids about a month ago, taking what he believed to be oxycodone. Initially, he took them by mouth, but then began crushing and snorting them. And he then attempted to perform a reinduction onto Suboxone on his own, the same way he had many times coming off of heroin in the past. But even after waiting 3 days since his last use of these oxycodone, he was not able to restart buprenorphine. He went into horrific precipitated withdrawal when he tried to restart his medication. So he's really scared. He's realized he's been using fentanyl this whole time. You know, his prior use was in the era of heroin not so long ago, and he asks for help getting back onto buprenorphine. But he says, I've missed a ton of work from these precipitated withdrawal episodes, and I'm worried if I miss even one more day, I'm going to lose my job. And finally, we have Anna. She's a 22-year-old woman who established care 3 years ago when she sought help with heroin and methamphetamine cessation after learning she was pregnant. At the time, she underwent inpatient induction onto buprenorphine and remained stable on the medication throughout her pregnancy, then followed with Project Nurture for groups and support after delivery. And when her daughter was about 18 months old, she stopped taking her buprenorphine. She really had hated the taste, just couldn't take it any longer. But she ended up returning to use, this time with smoked fentanyl instead of heroin. Between May and October of 2022, she was admitted to our withdrawal management 5 times for reinduction onto buprenorphine, and each time returned to use of fentanyl within a week. Anna's daughter was placed into Anna's mother's care, and Anna is beginning to despair of ever having more than visitation. So each of these patients are facing a situation that is common in Oregon today, but that was essentially unheard of just 5 years ago. They are dependent on an incredibly potent, high affinity opioid that can remain in the body for up to a month after last use. These properties of fentanyl are what makes treatment of opioid use disorder more challenging now than it has ever been, and why it's so critical that we modify our approach to treatment accordingly. But why is fentanyl the new heroin? I'm going to poll the room and I'll repeat your answer. Why? Emily Hitchcock says cheap. A small amount goes a long ways. Yes. Fast acting. People get it by mistake. There are not other things available. It's maybe not their preference. Yeah. You guys have a really good idea of what's going on. So I'm going to go into kind of my conceptualization of why we've seen this shift. I don't know that any of us can really fully explain it. I think there are kind of political, social, economic issues that all kind of play into it. But so for pretty much the entire 20th century, heroin was the main concern when it came to non-prescribed opioid use and overdose, right? A lot of you have seen that graphic of the triple wave of epidemics. In the 1990s, however, prescription opioid use became increasingly prevalent, with pain being the fifth vital sign, and overdoses began to rise. And so then initiatives to reduce opioid prescribing were put into place, but a large number of people had become exposed to or dependent on opioids, and many turned to non-prescribed opioids, and then often eventually heroin. And then for much of the 20th century, but particularly in the early 2000s, our foreign policy in the Middle East and South America focused really heavily on reducing poppy cultivation and heroin exports from those countries in an effort to reduce heroin use inside the United States, right? So at the same time that heroin use and therefore heroin-related deaths began to increase, the supply of heroin could not easily meet demand. Limited supply was further reinforced by increased border enforcement and penalties for heroin use and heroin trafficking. And the combination of this massive increase in demand for illicit opioids and an increase in risk associated with producing and importing those opioids led producers to seek alternatives to heroin, which is derived from raw opium from the poppy plant, right? So ideally, the opioid would not require acres of conspicuous poppy cultivation, which is kind of easily bombed and destroyed, and there's interdiction, right? It would be easier to conceal than heroin, right? Which heroin is actually relatively bulky, even in its purest form. So the ultra-potent synthetic opioid fentanyl was an obvious alternative. Ingredients to produce fentanyl and its chemical analogs are cheap, and they were not illegal in many countries at the time that this began. And as it has more effect per a given volume than heroin, it's more potent, it's easier to transport in small packages across borders without detection. Okay. So in a fairly short period during the 2010s, fentanyl became a common contaminant in US heroin. It was used to stretch the effects of heroin further and strengthen a given cut. This was also accompanied by an initial wave of these blue pills. Right? They were manufactured in presses to look like oxycodone, and in particular, like a specific version of oxycodone that was known to be easy to crush and then smoke, snort, or inject. And in general, the raw materials to make fentanyl are synthesized in China and then transported to the US through Mexico, although there are many routes. And blue pills are still everywhere, but it's now better known that the product is usually fentanyl, although not by everyone. And in recent years, powdered fentanyl is becoming more prevalent too. And for a while, different fentanyl analogs would come in waves as different methods of manufacture were used and different precursors detected and then banned. And increasing pressure, in particular from the US, then led China to nominally ban fentanyl analogs, and two key precursors in 2019. So in the last few years, we've been seeing increasing reports of potent non-fentanyl synthetic opioids. So examples include pink, also known as U47700, and a class of opioids called nitazines. So keep an eye out for those. So that's all fascinating, but why is it clinically important that people are now using fentanyl and not heroin, right? So let's talk for a few minutes about the things that we as providers need to know about fentanyl and why patients who use fentanyl are clinically distinct from those who use heroin. I'm going to review 5 points one by one. So in discussion with people who use drugs, I've learned that at first the arrival of fentanyl was really seen by some as a good thing. Fentanyl has a very fast onset of action by all the various routes of ingestion, and there's not much advantage to injecting as opposed to snorting or smoking. And that was initially perceived as a benefit, right? There's lower risk of abscesses, other infections if you don't inject. And in general, fewer people inject fentanyl compared to the proportion who injected heroin. However, I think it's important to point out that ultimately, fentanyl is not as desirable of an opioid as heroin. There's a reason heroin has been so enduring as a substance of choice for so long. The speed of onset, the euphoria generated, and the slow wane, they all contribute to the experience of heroin. That's why heroin, diacetylmorphine, really took hold as opposed to morphine or oxycodone or any of the other opioids that could have become the choice, right? In contrast, fentanyl kind of comes on startlingly quickly, and the effects tend to fade quickly. So this leads often to a need to dose more frequently for many people, which is time-consuming and disruptive. And because the fast onset and quickly waning effects doesn't feel as good subjectively, many producers then mix in a second substance, right? Something like the animal tranquilizer xylazine or a benzodiazepine. So tranq dope, benzodope might be ways that those are referred to prolong the effect, but then these additives can then lead to their own hazards and complications. We may see patients come in with concurrent intoxication from these second sedatives, which then don't necessarily respond to naloxone, right? And they may cause withdrawal syndromes that are not relieved by administration of methadone or buprenorphine. Another change is tolerance. So people who use fentanyl chronically often develop extremely high opioid tolerance, which can make substitution with methadone or buprenorphine very, very challenging. People just are not able to get comfortable. They can't match their opioid debt. And many patients experience withdrawal syndromes that appear to be more severe and more intense in fentanyl withdrawal compared to heroin withdrawal. Things like hallucinations, involuntary choreiform movements, intractable, excruciating low back pain that may even require hospital transfer. And the lipophilic nature of fentanyl also means that while its duration of action on the receptor is short, it rapidly distributes into the fat and can be stored there for quite some time. One recent study tested patients for fentanyl after admission to a residential treatment setting and found that urine tests remained positive for fentanyl an average of 7.3 days after last use of fentanyl. And one patient even discharged from treatment after 26 days, still testing positive for fentanyl metabolites. So just really, really protracted clearance. Now, the lipophilicity of fentanyl may also mean that body mass may affect the rate of clearance and the severity of withdrawal syndromes in ways we don't fully understand. And none of that has been incorporated into guidelines, but there is some case reports and case series showing that maybe there is some component there. And I'll speak in a few minutes about how this means we've needed to dramatically overhaul our approach to buprenorphine initiation across care settings. And finally, let's talk, of course, about the risk of death. Fentanyl has high potency in a small volume of pure product, meaning that the strength of a given cut is less predictable, right? It's not just that, there's many different fentanyl analogs, as I've mentioned, that are in the drug supply, and that creates further unpredictability. And then we have the fact that fentanyl's rapid onset of action leads to near instantaneous poisoning if the dose is too high, which doesn't give people much time to react or get help. And when circulation stops quickly, naloxone can't get where it needs to go, right? Even when it's administered right away. And so we're seeing often people need multiple naloxone kits along with CPR to reverse fentanyl poisoning in the field. And as if that weren't enough, fentanyl has unique side effect previously only documented in the anesthesia literature as wooden chest syndrome. It's where too rapid administration of high doses of fentanyl doesn't just suppress respiration, it can also directly cause chest wall muscle rigidity that is not reversible by naloxone. Okay. So that's the bad news, right? But today I'd like to spend some time on 3 important changes we can focus on to better care for this population. So first, of course, we need to dramatically increase access to evidence-based treatment for opioid use disorder. We need to re-examine our current strategies for withdrawal management. And we need to modify our approach to initiation of buprenorphine or methadone and our thinking about maintenance dosing of these medications. So let's dig into each of those. So when it comes to increased access to care, the need is great. We're all concerned about highly visible substance use across Oregon, and people talk about those who decline services when offered, right? I had the opportunity to work at the Hooper Detox and Stabilization Center longitudinally during my addiction medicine fellowship. It's Portland's safety net detox. every morning, a large number of people line up around the block outside of Hooper at 6:45 in the morning, waiting to be admitted. And every morning, a significant proportion of them are turned away because this 70-bed detox runs at capacity, right? The number of people waiting would be more if they knew they could get in, right? They know there's a good chance they won't get in. We need 50 of these in Oregon, right? We don't have them. That's one component of access. And there's a reason that there's a robust trade in diverted buprenorphine and methadone, right? Most people who have taken diverted medications did so to prevent withdrawal and reduce use of other substances. So for the intended therapeutic use, right? And 81% of people who used diverted buprenorphine stated that they would prefer to have the medication prescribed rather than purchasing it, but cited barriers of cost, wait times, and stigma that made using diverted medication the better option. So how can we make access and care easier? So we've already seen increasing requirements for addiction care experiences in undergraduate and graduate medical education, meaning that new graduates are likely to receive significantly more training than providers already in practice, right? Even in just the last few years, yes. And we need to continue to emphasize to our colleagues and to our trainees that addictions care is part of providing high quality whole person care in all care settings. And many of us already in practice need to be willing to learn these skills, or at least know how and when to refer, right? Because whether we like it or not, increasing access to these medications is a policy priority for the current administration. So to that end, we have just witnessed the end of the X waiver in January of this year. Prescribing buprenorphine for opioid use disorder is now within the scope of every provider registered to prescribe other Schedule III medications, and education around treatment of substance use disorders will be incorporated into standard DEA licensing requirements. So get ready. The government is also making it easier to meet patients where they are. The COVID-19 pandemic created emergency exceptions, allowing for prescribing of buprenorphine via audio-only telehealth and for accelerated access to take-home methadone doses from opioid treatment programs. So in the past, federal methadone regulations required patients to present in person for dosing 6 days a week and test negative for all other substances, including cannabis, for how many days before they could get one take home? "90 days. Okay. How long do you think they needed to present consistently to get a month's worth of take home? With no use of any other substance, including cannabis, with daily UDS. 2 years. 2 years. It is not easy to be on methadone, right? It is really difficult, maximally disruptive care, right? Yeah. So emerging research shows that relaxing these regulations, as they were in the COVID-19 pandemic, to avoid those big lines at the methadone clinic, people congregating, they allowed take-homes a lot earlier, a lot easier. It's overall benefited people seeking treatment and not increased harm. There's also a bill currently before Congress that would allow patients who have been stabilized on methadone to pick up their doses at a pharmacy when prescribed by that opioid treatment prescriber, which would substantially decrease barriers to methadone treatment, especially in rural areas. We also need to focus on the barriers that prevent patients with substance use disorders from accessing care for other concerns, right? Research shows that the primary driver of unplanned hospital discharge and in-hospital substance use in people who use substances is unmet need for withdrawal management and pain control while admitted. So increasing our skills in identifying and addressing these concerns will help us ensure that patients with substance use disorders are able to access and engage with all types of care. And this is an equity issue, right? People of color are no more likely to have a substance use disorder compared to white populations, yet non-white populations are more likely to be randomly drug tested, more likely to be taken off opioid therapy if they test positive for another substance, less likely to be able to access addictions care, more likely to be guided toward methadone instead of buprenorphine, less likely to complete addiction treatment when they're able to access it, and more likely to die by overdose. Among transgender individuals, having experienced enacted stigma and violence is associated with higher rates of substance use disorders. Unhoused populations face massive barriers to treatment and obvious dangers and harms. I think it's painfully evident that we are failing to care adequately for people with substance use disorders in general, and disproportionately failing minoritized populations. Okay, so let's say our intention is there. We want to improve our care. What do we do? We're going to talk about withdrawal. So I'm going to use this fairly unscientific graph I've created. You'll notice that, yes, there are units for the days, but no units for opioid receptor stimulation or where people feel comfortable. But this is how I visualize my management, and I hope it'll be helpful for you too. So withdrawal from heroin was fairly predictable, right? People might dose heroin 2 to 4 times daily to avoid withdrawal. And as tolerance develops, eventually euphoria is no longer possible and increasing amounts of heroin are needed just to stay out of withdrawal. As you can see, that starts to happen as time goes on. If you had a physical dependence on heroin and stopped dosing, you could expect to be in moderate withdrawal within 12 to 24 hours. That's a COWS score of about 10. And you'll see withdrawal symptoms peak at about 3 days. And then untreated, you'll start to feel better by day 7 or so. Now, because of the protracted clearance of fentanyl, it often actually starts to act more like a long-acting opioid. In fact, this curve might as well be methadone, right? Which is ultra long-acting. I call this kind of a slow phenotype of fentanyl dependence. If someone stops taking fentanyl suddenly, they may feel okay for actually quite a while in many cases. Now, by day 3, they're really starting to feel it. By day 7, they may be just starting to hit the worst of it. And patients, of course, report that withdrawal is much more intense than withdrawal from heroin, and it can seem like it's never going to end. Now, in other situations, fentanyl does act more like an ultra short-acting opioid. People may be needing to dose as often as every 1 to 2 hours to prevent withdrawal, and it can be exhausting. And I kind of call this the fast phenotype. It can be hard at the outset to tell which phenotype the patient will be, or if there's something in the middle, or if they have a second sedative like xylazine or benzodiazepines on board. They may not even know exactly what they're ingesting in many cases. I do ask how often someone is needing to dose, which can give me a really good clue as to whether they're going to be this particular pattern, and I'll get into why that's important. And if this is the patient's phenotype, they're going to be in severe withdrawal quite quickly. As I mentioned earlier, you might see hallucinations, choreiform movements, really extreme agitation and restlessness, intractable vomiting, just saw that the other day, nearly unbearable body aches. I've spoken to a colleague again who needed to require hospital transfer due to the severity of this syndrome from a residential treatment center. So what can we do? Well, in the early 2000s, providers were first learning about buprenorphine, and it was common to have the patient administer the first dose or 2 in the office. So you can make sure, oh, their COWS score is this, they're in moderate withdrawal, they can take 4 milligrams. Have additional medical supervision, right? That became less necessary as both providers and patients became more experienced with buprenorphine. But with fentanyl, we are now seeing more patients stay in the office again for pre-medication observation, be recommended for inpatient care due to the anticipated severity of their symptoms. So we are seeing this need to come into more intense care again, which is really unfortunate because access is already so low. And for withdrawal itself, the armamentarium has not changed too much. So in the outpatient setting, we'll often prescribe from an order set containing these medications and often tailor to the symptoms the patient has found most bothersome in the past. You'll notice that a couple of these are off-label, but this is pretty typical of a comfort medication order set. In the inpatient setting, we may also offer a benzodiazepine. So diazepam works well in my experience, and I will often give hundreds of milligrams of diazepam over a couple of days when somebody is in inpatient withdrawal management. It really just barely allows the patient to dissociate a little bit from their discomfort and keeps them in treatment. Olanzapine can be really helpful for patients with agitation that is refractory to all of the other medications. Again, that's off-label. Honestly, I wish I had more to offer at the moment because it's a horrible thing for someone to have to go through. Let's move on how to initiate methadone or buprenorphine in the fentanyl era. So I recently attended the National Conference of the American Society of Addiction Medicine, reflecting, cutting edge current practice. Things are changing so quickly that a lot of things are not published yet, right? But addiction specialists are finding that the traditional maximum of 40 milligrams of methadone on day one, which is the limit set by federal guidelines in the outpatient setting, it's not cutting it, right? Patients are leaving treatment at staggering rates before they can reach a dose that comes close to matching their existing opioid tolerance. So one session at the conference was titled Methadone in the Fentanyl Era and included rapid titration protocols from San Francisco General Hospital, OHSU, Hopkins, and Boston Medical. As you can see, OHSU's protocol makes it possible to reach 100 milligrams of methadone daily on day 4 of dosing in the hospital, right? It's possible to, you don't have to, there's, PRN doses and all of that, but that's a rapid acceleration on methadone. I still advise caution because dose stacking with methadone is a major concern, but in patients who are young, have previously tolerated high doses of methadone, more rapid titration seems to be the way of the future. And then anecdotally, methadone providers also report needing to use higher and higher maintenance doses to see patients cease their ongoing fentanyl use. We would see people stop using heroin in the range of 60 to 80 milligrams of methadone a day, and pretty much always by 100. And one methadone medical director locally told me at one point, 200 is the new 100. It's a different world out there, right? Now, as we saw a moment ago, cessation of heroin typically results in a moderate withdrawal syndrome within 12 to 24 hours. And because of the relative opioid agonism of buprenorphine compared to heroin, so buprenorphine is a partial opioid agonist and can only give you about 50% of the stimulation at the opioid receptor that heroin will give you, but it binds very, very strongly. It'll kick anything else that's in there off of that receptor. Once a patient is in moderate withdrawal from heroin, they can take a largish dose of buprenorphine, 4 or 8 milligrams, just 12 to 18 hours after their last heroin use and will feel better overall. So this is traditional buprenorphine induction, right? They get more opioid signal from the buprenorphine than they were getting from that waning effect of heroin, and replacing the remaining heroin with buprenorphine is a net gain to bring them back into that comfort zone, okay? And because it's a partial opioid agonist, buprenorphine typically can't induce euphoria in somebody with an opioid tolerance, which is what makes it so great for treating opioid use disorder. You get them comfortable. You're never going to get to euphoria. Now, as we saw before, fentanyl can act like a long-acting opioid, and the withdrawal might mimic high-dose methadone cessation, right? It's slow to come on, very protracted, quite severe. However, just like with methadone, it is risky to start buprenorphine even after multiple days. Enough fentanyl is still on board that even 3 to 7 days later, and with a COWS score indicating moderate withdrawal, 4 milligrams of buprenorphine can and often does precipitate withdrawal. So there's a net negative in opioid signal, and the resulting instant onset withdrawal is so horrible that some people even report PTSD-like symptoms afterward. It is really it's like The Exorcist. It's terrible. It's terrible. So there are 5 general strategies that I've seen emerge as an alternative to the traditional buprenorphine initiation, which is in most cases not working for people dependent on fentanyl. So the relative merits of which are hotly debated among addiction specialists. None are how buprenorphine was studied or labeled, right? And none has emerged as a clear champion, but each has its uses. So I'm going to go into a little more detail on these. So the first to emerge was the Bernese method, also known as buprenorphine microdosing, and now known more accurately as low dose initiation, right? Because it's not really a microdose, it's a low dose. Now, low dose initiation was first reported by a research group in Bern, Switzerland, hence Bernese. It was designed to assist patients in transitioning from heroin or methadone to buprenorphine without the need for any withdrawal period. So it involves continuing your full agonist opioid on a regular schedule at the same dose as the patient usually would, and then overlapping a gradual and regular up titration of buprenorphine to sneakily replace the full agonist with buprenorphine in kind of a push-pull alternating thing. So withdrawal never gets too bad. You're always just barely bringing them down, bringing them up, bringing them down, bringing them up. So on day 7, the full opioid is stopped and the patient shouldn't feel any difference, right? Buprenorphine has such a high binding affinity that it has fully replaced the other opioid over 7 days. This works pretty well with people on methadone 30-ish, a little dicey on methadone 100. I've seen it work, I've seen it not work. One concern, however, is that many clinicians in the outpatient setting are uncomfortable asking a patient to continue using heroin, right? In the inpatient setting, other full agonist opioids like morphine can be used to bridge from heroin to buprenorphine. Now, this does work with fentanyl and initially seemed pretty promising, but hasn't panned out to work as well as we'd hoped. Starting with 0.5 milligram of buprenorphine on day 1 might precipitate someone enough that they just can't complete the initiation. And the instructions can be pretty confusing for us, let alone for a patient to undertake themselves at home, right? Many clinicians have also experimented with high dose initiation, and there are some here in Oregon who swear by it and may be using it at your nearby hospitals. Peace out. So these clinicians start with a large dose of buprenorphine without necessarily waiting for the onset of withdrawal, and then just give more and more to push into and through precipitated withdrawal, often giving more than 32 milligrams within 24 hours. I have not personally had much success with this method, but it's definitely out there and being used. One of the most dramatic new initiation methods is called Quick Start. So a local telehealth provider, Boulder Care, pioneered it and published a case report in the Journal of Addiction Medicine. So some pre-medication is given, clonidine, gabapentin, and then the patient self-administers intranasal naloxone. Within 15 minutes, withdrawal is severe, and 24 milligrams of buprenorphine is administered. The patient just holds on tight for about 30 minutes, and then the worst is pretty much over. Now, this strategy is seen as pretty risky, right? Has a lot of unknowns, but you should be aware that patients in our region may have been through it, okay? I personally don't recommend it at this time. So the question is, are folks doing this out on the streets themselves? I'm sure they are. I have not personally spoken to anybody who has. I've only spoken to people who have done it with Boulder Care. But I believe that Boulder Care actually kind of got the idea from a patient. Yeah. Now, the method that I use most commonly, and variations of which I see used the most in withdrawal management here in the community, is a rapid low dose induction. So the method combines some qualities of the Bernese method with high dose initiation. At Fora Health, where they have a withdrawal management center here in Portland, they call it their Goldilocks protocol, okay? So here is our standard inpatient approach in our withdrawal management setting. So we have access to lots of comfort medications. We can ensure a somewhat complex regimen can be given reliably. We give 1 milligram of buprenorphine when they first arrive, and then every 8 hours, 3 times, then 1 milligram every 3 hours, 8 times, and then 8 milligrams 3 times daily. Not complicated at all, right? But as you can see, we're trying to keep people kind of in that zone. We don't want them to go too low. We don't, because if you push it too fast, they're going to go into severe withdrawal, right? The first day and a half of this can be pretty unpleasant, encroaching withdrawal syndromes coming on at unpredictable rates, lots of cravings. So again, one of the mainstays of our inpatient transition strategy has become benzodiazepines. We used to never give benzodiazepines in opioid withdrawal, but fentanyl withdrawal is another animal, and I'm a convert. We've seen that using that diazepam has really made the experience much more bearable and decreased unplanned discharges. In the outpatient setting, I provide 4 2-milligram tablets, so 8 milligrams total is 2-milligram tablets, and comfort medications, and ask the patient to take a tiny portion of the tablets every 1 to 2 hours once they feel they are starting to have more severe withdrawal symptoms. And then once the 4 2-milligram tablets are gone, they can start with half of an 8-milligram tablet and have low risk of precipitated withdrawal with that 4 milligrams. I ask them to start taking halves of 8 milligram until they feel well, and then can do 8 milligrams 3 times a day. Usually takes about 2 days. Now, remember how I mentioned that there is that second phenotype, the fast phenotype of fentanyl dependence, where it resembles an ultra short-acting opioid. So these are the patients who will walk out on you an hour after their first 1 milligram buprenorphine dose. There's absolutely no way they're waiting another minute, let alone 8 hours for the next 1 milligram dose. You made them feel a heck of a lot worse than they already did, which was pretty terrible already, and they are not happy. So in addition to benzodiazepines, in these cases, we have learned to pivot after that first dose and speed up the low dose initiation. And this is where recognizing it in advance can be really helpful. So we give 1 to 2 milligrams every 2 hours as needed for cows greater than 10 until they've had 8 milligrams in total, then give an 8 milligram dose and repeat that 3 times a day. So you can see it's just an accelerated version of the rapid low dose. It's a bit dicey trying to get patients to hang in there with you, but more often than not they do, and we'll be on the other side within 48 hours. The next challenge is supporting people to stay on buprenorphine. So buprenorphine can often only barely keep someone out of withdrawal when they are first transitioned onto it from fentanyl. And in a great number of cases, they're not very comfortable, even on maximum doses of buprenorphine for multiple weeks after transitioning. They tend to be extremely anxious, they have trouble sleeping, dysphoric mood, very high risk of just throwing in the towel and going back to fentanyl. If you've seen me speak before, you might remember that buprenorphine had a number needed to treat of only 2 to keep someone in treatment. In the age of fentanyl, that number has gone way, way up. Okay. We don't actually really know what it is because everything is changing so quickly, but there are some novel strategies we might consider to better the odds. So there's a growing movement to push the previously accepted dose limits of buprenorphine. The thought is that with fentanyl dependence, we don't have any guarantee anymore that a dose of 16 or 24 milligrams is actually saturating receptors, right? The data is not there for that. Anecdotally, there is a subset of patients who seem to turn a corner at 32 milligrams, or in some cases even more. And this is particularly compelling in a controlled setting like residential treatment, where there's a low risk of diversion of those doses, right? So we may see higher doses approved on insurance at some point or incorporated into future guidelines, though that hasn't happened yet. And then there's long-acting injectable buprenorphine. So brand name Sublocade, a subcutaneous monthly depot, has been FDA approved since 2017. It's approximately equivalent to 8 to 24 milligrams sublingual daily and reaches steady state after about 3 monthly injections, although it does continue to provide some level of stimulation for multiple months, even after just 1 injection. It's great for patients who are at risk of having their medication lost or stolen, or who can't stand the taste of buprenorphine sublingual. Our clinic has over 40 patients who are stable on injectable buprenorphine, many of whom have been presenting consistently for their monthly injections for years. And then brand name Brixadi, available as either weekly or monthly injections with a wider range of doses, was just FDA approved last month. and should provide even more options. So let's come back to our cases and apply what we've learned. Yes. Yeah, so Sublocade cash price is close to $2,000 per dose. It's the same price for 100 milligrams and 300 milligrams. You start with 300 milligrams, repeat that the next month, and then go down to 100 is the standard protocol, but you can also continue at 300. For our patients, we submit a like a advance request to know what their out-of-pocket is going to be, find out what it is, see if that's doable for them, and then we often will ask for copay support from the pharmaceutical company. Yeah, good question. Brixadi, don't know yet. Yes. Yes, this is a version of buprenorphine. It is buprenorphine only, subcutaneous depot, slow release, 300 milligrams a month. Why is it so expensive? There is, yes. What's that, Claudia? Yeah. Yeah, it's a patented delivery method, right? The depot formulation. Yeah. Yep. All right. So back to Sonia. She's our patient with the endometrial adenocarcinoma. She's dependent on fentanyl, swallowed orally, and also has the severe cancer pain. So for her, I chose low dose initiation of buprenorphine in the outpatient setting with ongoing use of her prior opioid. So her pain wouldn't be untreated at any point. No need for withdrawal. So these were the instructions that I provided her. I provided her with 22 2-milligram buprenorphine tablets and instructions for a standard low dose initiation. I suspected her tolerance was on the low side for fentanyl since she wasn't using it intentionally, was swallowing it, which has lower bioavailability. I let her know that she could pause at the dose that felt comfortable. And in reality, she ended up being able to discontinue her fentanyl use on day 2 and was comfortable with her pain on day 4. So she stabilized on 2 milligrams twice a day leading up to her surgery the following week, and she ended up increasing her buprenorphine to 4 milligrams 3 times daily in the post-operative period, and also received some oxycodone for breakthrough pain. She began tapering off buprenorphine as soon as her post-operative pain had resolved and was successfully off it 2 months later. And 7 months after that, she is doing well, still seeing our counselors, not for addiction, just for other things. And only requiring routine surveillance for her cancer. And let's look at Ray. He's dependent on large amounts of snorted fentanyl, and his girlfriend just threw away all of his pills. He doesn't have any more supply. Now, for him, I suggested a rapid low-dose initiation in the outpatient setting and prescribed as-needed clonidine for his withdrawal symptoms. So here were my instructions for Ray. I asked him to take half a tablet, 1 milligram, every 1 to 2 hours as needed for severe withdrawal symptoms until you've taken 4 of the tablets in total, 8 milligrams. Then resume your 8 milligram tablets and increase to doses of half to 1 tablet, so 4 to 8 milligrams, until comfortable or at prior dosing. 20 milligrams daily was his prior dose. I called him the next day, and he had successfully taken 6 milligrams in 1 milligram increments over 24 hours since we'd spoken. It was not fun, but he had done it. I encouraged him to increase his doses at that point, and by day 3, he had taken another 24 milligrams in total in 4 milligram increments, but was still restless and uncomfortable. I advised him to increase up to 32 milligrams daily for a few weeks, and then back down to 24 milligrams as he gained stability. And 6 months later, he continues on 24 milligrams daily with no return to use. True story. Now, Anna is dependent on smoked fentanyl in high quantities and heroin and has previously been unable to stabilize on sublingual buprenorphine taken at the usual highest dose, 24 milligrams daily. So she was admitted to inpatient withdrawal management and underwent rapid low-dose initiation of buprenorphine, as I described, over 3 days. This time our team discussed the option of long-acting injectable buprenorphine. She was amenable to trying it, and we administered the injection before she left withdrawal management. She was also discharged with up to 8 milligrams sublingual buprenorphine daily to supplement the injection. Despite that, she returned to use of fentanyl within about a week, 5 to 10 pills a day by smoking. But she did show up for her second injection 36 days after the first and received it without incident. After that injection, she stopped using fentanyl for several weeks. She had another brief return to use in month 3, but continued to present for monthly injections. And she recently received her 8th injection, has been abstinent from other opioids since December of 2022. And her mom and her 3-year-old daughter often accompany her to her appointments. She's working toward regaining trust and hopefully eventually custody of her daughter. So that was a lot and some pretty advanced topics, but I want you to know what's available and what specialists are doing in this new era of treatment. I want to encourage you to incorporate at least a small aspect of this knowledge into your own practice and consider trying one of these strategies. And you can always reach out to your friendly neighborhood addiction specialist for guidance and support. And in addition to working with the consult services here at Providence, I would also encourage joining one of the addiction treatment ECHO courses offered through the Rural Practice Network. You can discuss cases with local experts and learn more on your lunch hour. I know several of you have attended. So in conclusion, cheap supply and increasing consumer demand make fentanyl the most available non-prescribed opioid in the US market today. Fentanyl's high overdose risk, high potency, high lipid solubility, and protracted withdrawal syndrome are all excessive compared to heroin. And as of January 2023, buprenorphine can now be prescribed by anyone licensed to prescribe controlled substances, can currently be prescribed via audio-only telehealth, and methadone regulations are currently relaxed compared to before the pandemic. Low-dose initiation, rapid low-dose initiation, and accelerated rapid low-dose initiation are novel strategies that you can try to use for buprenorphine initiation in the age of fentanyl. And higher maintenance doses, judicious use of benzodiazepines in acute withdrawal, and long-acting injectable buprenorphine can be additional supports to help patients stop their use of non-prescribed fentanyl.
Well, many, many thanks, Dr. Marshall, for both a pragmatic and inspiring talk. I have at least one question here online. Maybe we'll open with one in the room and then go to our online audience.
Dr. Schaefer.
That was extraordinary. Thank you. I'm impressed by the complexity of the instructions that you sometimes give to patients. God forbid I have a patient who needs Lasix every other day. That never goes well. Can you comment on how and why this appears to work with these patients?
I think that patients who use substances are used to being their own pharmacists, nurses, doctors. They are so experienced and often just need the information that I have to give them the principles in order to be able to do it themselves. And so when I talk about how fentanyl is different from heroin and why we need to start low and go slow, they realize, oh, things are different. Okay, I understand that. It doesn't work all the time. But I find that many, many patients are more than capable of managing their own withdrawal symptoms if they understand the principles of the medication that they're using. It is, I think we underestimate them, especially patients who have done a lot of research. They know what they're doing. Yeah, it's a good question though. And often these instructions are too complex, and I'll often, for people for whom this is the first time, I'll recommend that they go to inpatient withdrawal management. I say, let us come and take care of everything. You know, come, let us take care of everything. We'll just give you medications. You can just lie in bed. So.
Great, thank you. A question from online. Is there a push for Suboxone prescribing by PCPs recently, given the fentanyl epidemic in Portland? We were not taught any of this during residency and do not feel comfortable prescribing. Also, we don't have a structured program for addiction treatment. Our psychologist is not trained in addiction medicine. Wouldn't referral to a Suboxone clinic be a better option?
Yeah, so it is part of general practice. I mean, if you're prescribing opioids, you should probably also know how to prescribe buprenorphine. It's no more dangerous than insulin. It's a little tricky. You do need to be trained, and that is the responsibility of the institutions training you and expecting you to use these substances. But I do think it is part of general practice. I think for more complex cases, it's absolutely indicated to refer to an addiction specialist. But the need is so incredibly great that there are not enough addiction specialists or Suboxone clinics out there to cover the need. Personally, I have a lot of patients who are extremely stable on buprenorphine, have been 10, 15 years without incident. Check on them once a year, refill-based, visits. I refill tons of buprenorphine every day. They don't need me as an addiction specialist. They could very well be managed by primary care. At Kaiser, we do have primary care providers who have stepped up as interested in doing medication for opioid use disorder, and we partner with them to support them when their cases become complex. So that kind of system, I think, might be a good way to guide primary care providers into this practice.
Thank you, Kate. Just as some of us who have been prescribing buprenorphine and have gotten comfortable with 24 milligrams a day, certainly there's lots of other medications that I'm prescribing sort of off-label, or, increasing the duloxetine to 120 a day, despite that's not what the paperwork says. What kind of documentation or sort of CYA behaviors should I be doing around 32 milligrams? And is anybody going over 32 milligrams?
Yeah, so first of all, I think just like with any other off-label use, you can document, hey, I think benefits outweigh risk. Patient is not at therapeutic goals with the usual maximum dose. Experts recommend giving higher than usual doses a try. I have one of those little check boxes when I order more than 24 milligrams. Benefit outweighs risk is what I usually choose. So yeah, I think it is becoming such accepted practice that I don't think you would be questioned. I've talked to folks at the OMB about this, and they absolutely endorse, novel strategies, meeting the changing landscape with best care for patients, and really encourage us to follow our judgment and do what we need to do for the patient in front of us.
So for people that are on maintenance Suboxone and they have a return to use, I think previously I heard like with oxycodone and heroin, they may oftentimes just keep using their buprenorphine while they're using or return to it pretty quickly. But with fentanyl, it sounds like with the return to use, they're more, in your stories, they're more likely to stop the buprenorphine altogether. Does the dull the effects of the fentanyl? Is it just that people get sort of disorganized and back into old habits? Do you see some people that continue their bup while return to use with fentanyl? Like, how is that different than other opiates?
Yeah, that's a great question. There are definitely people who continue a small amount of buprenorphine to kind of create kind of baseline withdrawal protection while they continue to use fentanyl or other substances on top of it. I personally, I wouldn't discourage that. Right. I think it's better than not using buprenorphine. I don't know that I really see it at any different of a rate than I did with heroin. It doesn't blunt the effect of fentanyl as much as it did heroin, though. And that's what we're seeing with methadone, is that people are still able to get euphoric effect from fentanyl over 100 milligrams of methadone daily.
Great. Well, I want to go ahead and acknowledge that we are right at the top of the hour. Thank you so much, Dr. Marshall, for joining us today.
Thank you.